pediatrics, and my resource faculty Dr. from the Department of Microbiology. So without delay, now let's begin. So these are my objectives which I am going to cover today here. So for the diagnosis of the HIV infection, the available resources this can be done by the by complete history that the symptoms presented by the patient as well as the different laboratory tests that is done in our setting, right? There are many three types of the laboratory tests that is done here that is classified as the screening test, supplemental test, and the confirmatory test. So in the screening test that will include the ELISA and the rapid diagnostic test. Similarly, in the supplemental test that will include the Western blot test and line immunoassay. Similarly, in the confirmatory test that will include the detection of the P24 antigen, HIV, RNA, as well as the viral culture method. So before ordering any laboratory test to the patient infected with HIV infection, this test should be taken by the 3C. The 3C first one is the consent, confidentiality, and counseling. The consent should be taken in the written format from the patient here by explaining the nature of the test which we are going to offering, right? And then another one is the confidentiality. The confidentiality of the patient must be must because we should not write the HIV positive in the report form of the patient of the HIV infected. Then after counseling should be proper counseling should be done with the patient to motivate the patient so that he can disclose the result to his family members or his partners so that appropriate behavior change can be taken to prevent this transmission of the HIV infection. Now let's talk about individually. Number one test will be the detection of the P24 antigen detection. P24 antigen. It is mainly done by the ELISA test, right? And when we see the natural infection of the HIV infection, this antigen will earlier appear while comparing to the other antigens. So it will mainly appear in the days 12 to 26 of the following HIV infection, and then it lasts for the 3 to 4 weeks, and then it will disappear when the seroconversion occurs. That is the antibody will appear in the serum. Then after the advancement of the AIDS, presence of the AIDS disease, when the onset of clinical disease starts, again this P24 antigen will reappear. Then at that time also we can detect the P24 antigen and confirm the diagnosis of the HIV infection. Our another test is the antibody detection test. Antibody is the most commonly used technique that is done in our setting also, and it includes the many two tests that is already I have mentioned here, that is a screening test and another is supplemental test. So screening test that will include the ELISA and RBT. So ELISA is that enzyme-linked immunosorbent test. It mainly involves the detection of the antibody to the viral code inside. So it usually takes the time 2 to 3 hours and it is the most sensitive and specific test. The main advantage of this ELISA test is more large number of samples can be done at one time. And another test is our rapid diagnostic test. It is the most quickest test because result is within the 30 minutes, and it also easier to perform, and it is the most effective and specific test. And its advantage is that no any sophisticated instrument are required for the diagnosis for doing this RBT. So when in the ELISA test we can collect the sample like the blood or the plasma and serum. Then for that we have to the HIV antigens should be prepared from the either continuous cell line or the recombinant technique. And then this HIV antigens should be coated onto the coated microtiter well that is on the ELISA. And then after this microtiter antigen coated microtiter well is taken, and then our serum will be added onto the microtiter well. And then after if the antibody will present in the serum, that will bind to the antigen in the HIV antigen coated microtiter well. And after that we have to add the anti-human immunoglobulin to the microtiter well, and then suitable smaller forming substance will also added there. So if any antibody will present here, that will automatically a detectable color is formed that will indicate our test is a positive test. But as I earlier mentioned, it is a screening test. So there is a chance of the false positive as well as false negative also. So we should consider in this condition also, like false positive can be there in the condition like the syphilis or the malignancy or lymphoma. Similarly, in the false negative can be there during the window period. So if this test we apply during the window period, there is a chance of the false negative that will not confirm the diagnosis of the HIV infection. And also if the false negative can be there, there is a B-cell dysfunction also. In the RBT test, there is algorithm also in the RBT test. Mainly in our setting, 3 assays are used here, that SA1, SA2, SA3. SA1 includes the Bigrami, SA2 includes the Unicode, and SA3 includes the Start. Among these, the most sensitive one is the SA1. So initially the SA1 is the most sensitive just when it is done, and then after second and third we do the SA2 and SA3. Then our next technique is the Western blot test, which is the supplemental test. So the main function of supplemental test is it will validate the result of the screening test we take from the either ELISA and RBT. So in the supplemental test, how it is done here? When first we have to the HIV antigen is separated and then it will be plotted as a nitrocellulose paper strip will be there. So as we know that in the HIV there is three types of structural genes are there. That is the gap, pole and impro. So these structural genes code the specific viral proteins. So these viral proteins are plotted onto the nitrocellulose paper strip. For example, gap is that will mainly code the P18 antigen, P24 antigen, P40 antigen, P55 antigen. Similarly, in the envelopes in that will code the P31 antigen, P55, 56 and the P55, 51 and P65 antigen. Similarly, in group G that will code the glycoproteins 41, glycoprotein 120 and the 160. So this antigen will be plotted on nitrocellulose paper strip and then our test serum that will be collected from a sample will allow to react to this test strip. If this any antibody will present in the test serum, that will bind to this antigen here, and then after we also add the MC human gamma protein cross-reachable enzyme and also follow substrate added. So on the test strip, if the antibody present, the band will appear. If any band will appear, that will indicate that our test is a positive test. So according to the two criteria has been given, that is according to WHO and the CDC differently. So according to if the two bands will at least two bands appear, that bands should be out of the envelope band. That should be either out of glycoproteins 120, 160 and 41 can be there. So if two bands will appear without involvement of gas or four bands, then that will indicate the positive test. But in the case of the CDC, I mentioned that this any bands can be appear either gas encoded or the pole encoded or the envelope encoded bands. So in this way we can supplement our validate the test of the screen test by the Western blot test. Now our next test will be the viral RNA detection test. Like this viral RNA and DNA PCR will be included in the viral nucleic acid testing. Means among them the viral RNA detection is the most gold standard testing for the diagnosis of HIV infection, and also it's a very good tool for the diagnosis of HIV infection during the window period. Because during the window period no any antibody will be appear in the blood. So in that condition we can use this viral RNA detection, and it is also most sensitive and specific test, and it also helps in the monitoring of the viral load. So it will help for the diagnosis as well as monitoring of the level of viremia in the blood also. Another test that will be included in nucleic acid testing is the DNA PCR test. This DNA PCR is mostly done in the case of pediatric patients, that will be the either infant or the any children before the 18 months of the age, right? So it will help to resolve the inconsistent finding of the ELISA if done, because in the case of the children before the 18 months, the antibody will immunoglobulin C will be either macromolecularly transport or the that antibody either formed in the patient, it can ELISA cannot differentiate it. So in that condition we have to use the DNA PCR, so it is a very sensitive test in a specific test in the condition of the pediatric patient. So now we have studied the different laboratory tests for the HIV infection, but we cannot randomly order any laboratory test with any phase of the infection. So we have to have the proper idea about the natural course of the infection, so that we can apply the appropriate test at the appropriate time. For example, this figure has beautifully explained the different phases of the HIV infection. For example, there is Achilles period is there, window period is there, and acute infection. So in the Achilles period, the malic period of the 10 to 14 days, where our available any SS cannot detect any marker of the HIV infection. So in that condition, we cannot detect the HIV infection through our antibody-based assay or any antigen-based assay. So, but this will be 10 to 14 days. Then after 10 to 14 days, here, that is the end of the Achilles period, there will be the appearance of the HIV RNA test. HIV RNA in our serum. So in that condition, we can apply our nucleic acid testing here and this RNA PCR, and we can detect at that condition. Then after the appearance of after 14 days, the HIV RNA P24 antigen will be appear in the serum. That can be detected by the antigen-based assay. After the 1 week of the appearance of the P24 antigen serum in our serum, antibody will appear that in the blood that after almost 3 weeks, and after 21st day. Then in that condition, after 21st day, we can use any antibody-based assay. Then another period is window period. So it is the period between the HIV infection to the field of detectable antibody in the serum, right? So it will be the period of around 21 days. It also has given that 3 to 12 weeks can be there. But here you can see that after the 21 days there is a window period here. So in that case, if you use any antibody-based assay, you cannot detect the antibody in that period. So after the day in the serum conversion, means appearance of antibody will appear in the serum after 21 days. So if we use any ELISA test, for example, there is one ELISA after 21 days, then we can detect the antibody to the viral proteins. And this fourth generation, there is an ELISA, the fourth generation, first, second, and third and fourth generation has been given say that the first generation ELISA is used, it can detect antibody only after 35 days. So previously it is known, but now they modified ELISA has been formed here. Like the fourth generation ELISA detect the antibody after 14 days, and so we use now the fourth generation ELISA that detect the antibody after 21 days. So in this way we can use the appropriate laboratory test by knowing the different phase of the HIV infection. So after knowing the different type of the laboratory tests here, our national guideline program has given the different algorithm for the diagnosis of HIV infection separately in the case of the infant, children as well as adult. So infant has taken children before 18 months of age, so this is the diagnostic algorithm here. See here what happened in the first we have collect the sample, and serum is collected within the 48 hours of the birth of the infant, right? And then this sample will confirm the NAT test. NAT test is nucleic acid testing, that is the DNA PCR already I have mentioned. If this DNA PCR or NAT test comes positive here, we have to start the ART immediately in the infant, and along with that our second test should be also done to confirm the status. But if the first test as a what is negative, so interpretation of the negative test will depend either the children is breastfeeding or not, because the breastfeeding is acquiring the chance of infection to the children than the children that is not non-breastfeeding. So if the second on doing the test become the negative here, we can guideline has given that we can repeat the test at the 4 to 6 weeks of the age of children. In that condition also, if the test comes positive, we can start the ART and second test can be done to confirm the status. But in that condition also, if the test comes negative here, we should repeat the test at 9 months of age. And same will occur if positive, we should start the ART, second test done. If negative here, then antibody test can be performed at 18 months of age or 3 months after the cessation of the breastfeeding. So in that condition, we can diagnose the HIV infection in the case of the infant or any children before the 18 months of the age. Now this is the diagnostic algorithm that is given our national program again for the adult or any children above the 18 months of the age. Here in the children we have mentioned the nucleic acid test use DNA PCR used, but here we use the RDT, this rapid diagnostic test already I have mentioned. So as I have mentioned, 3 assays are used here, that is determine Unicode and STAT. Right? Among them, determine is the most sensitive one. So in above 18 months of age, we are suspecting any adult having HIV infection. We first do the assay 1 and the determine will be performed. If the assay 1 comes either can be positive or negative. Suppose assay 1 comes positive, then we need to go for the second assay, that is assay 2 is Unicode. If assay 2 is assay 1 is positive, assay 2 done. If assay 2 can be either positive also negative also. So let's talk about first one. Suppose A2 comes positive, then again we do the third assay, that is A3. If A3 can be either again positive or negative. If all A1 and A3 is positive, then we report the case as a HIV positive. But if this while doing the A1, A2 and A3 comes negative, then we can report the case as a HIV inconclusive and we repeat the test in the 14 days. Now let's go to this A2 here. Suppose we do the A1 comes positive, we do the A2, then A2 can be negative also. So if the A2 comes negative here, we again do the A1. If A1 comes positive, then we have the A1 positive, A2 negative, again A1 positive. So we report this case as inconclusive and again retest to be done in the 14 days. But by performing the A1 on the second time, if it again comes negative here, we should report the case as HIV negative. So in this way, if what is the first case, while doing the SA1 comes negative, it is reported as HIV negative. So in this way, we can diagnose the HIV infection in the case of the adult or any children above the 18 months of the age. So this is the all diagnostic algorithm, in this way we can diagnose any HIV infection in any patient, right? So now let's talk about the treatment of the HIV. So main treatment of the HIV infection is that combination antiretroviral therapy, and it is mentioned that any children or adult living with the HIV infection should be treated immediately with the ART regardless of the CD4 cell count or any clinical staging, right? We should immediately start the ART. We should not cannot wait for the result of the either CD4 count or any clinical staging. So but before starting the antiretroviral therapy, we should keep in mind these are the goals that we are targeting while starting the ART, because this should be in our mind. So the goals can be either clinical goal can be there, biological, immunological, therapeutic. Clinical goal is we should start the ART keeping in mind that there should be a prolongation of life of the patient as well as improvement in the quality of the life of the patient. Then in the biological, there is a viral, we should mainly look to the viral load will be detected here. There should be a greatest possible reduction in the viral load should be there. And then in the immunological goal also, in the immunological there will be mainly the CD4 cell count here. Then the CD4 count should be also decreased. And in the therapeutic goal, there should be a rational sequence of drugs and mainly that will be helped to achieve our all above clinical, immunological and biological goal. Along with the there should be limiting the drug toxicity as well. That should be facilitate the adherence to be facilitated. And then after there is preventive goal. And the preventive goal, if you are using the ART, we should keep in mind there should be the reduce the HIV transmission due to the suppression of the viral load. So these goals should be in our mind while starting the ART to any patient. So there are many different classes of drugs and given that and used in the antiretroviral therapy. These are the different classes of drugs. For example, there can be the nucleoside reverse transcription inhibitor that will mainly include the 0-body, line-body, STA-body. Nucleotide reverse transcription can be here that will be mainly tenofovir. Similarly, non-nucleotide NRI, non-nucleotide reverse transcription inhibitor can be there that will mainly include the word nevirapine and incompetence. Similarly, protease inhibitor can be there that will mainly include the word ritonavir, etazanavir and spanavir. Similarly, the integrase inhibitor. Vatic gravity and doliprane gravity has been given here, and then another CCR5 inhibitor given that is the marapiro, and another is the bigger inhibitor that is the antiviral. So these drugs will act when we using the antiretroviral combination of drugs and use. That combination of drugs will act on the different stages of the life cycle of the HIV infection. So here is the for the prevention or for suppression of the viral load, which monotherapy is not used. We use the triple drug therapy. So now before starting the ART in the case of the adult, we should do some baseline investigation should be done here before starting the ART. You know the immune status as well as renal function and the liver function of the patient. Right? These are the some baseline investigations that we should do the conduct the TB screening as well as the chest X-ray to the patient. Or if the patient is a symptomatic of TB or chest X-ray abnormal, we should order for the sputum or the estriol prescribed by the TB expert. Then we should also conduct a test for the BTR for the syphilis also. We should also test for the hepatitis and C infection. Complete blood should be also assessed and along with the CD4 cell count, because that will to know the baseline value of the CD4 that will help us in the monitoring in the future while the patient is on the ART. And we have also, if the patient is female, we should do the pregnancy test also. Apart from that, some laboratory parameters, that is drug specific laboratory parameters, should be also done as before starting the ART. This will help us to know the side effect of drug occurring in the future. For example, if we are planning to include the tenofovir in the drug regimen, so we have to control the blood urea and creatinine, because the tenofovir side effect is that is a renal toxicity that will cause the acute kidney injury. Similarly, we should do the alanine aminotransferase if we are planning to start in the W2 gravity, because it has a side effect of hepatic toxicity. So this baseline investigation should be done before starting the ART in the case of the adult. So this is now what we start is what is the should be the choice of drug in the antiretroviral therapy. So our national guidance has given out this is the first line regimen that should be used here. For in the case of the adult, for example, there is a W2 gravity here, this is the lanibody, this is the tenofovir. So this is our first line regimen. Here we should mention that if previously this W2 gravity is not used. Here the main principle of this antiretroviral therapy is there should be the three drugs should be there, the two different classes of drugs. Initially, two nucleotide reverse transcription inhibitor has been added, and one drug that is from the item protease inhibitor. But recently, this W2 gravity has been added in the first line regimen, because while doing the research in our population, it has been shown that there is the greatest reduction in the viral load as well as higher gain in the CD4 cell count by using this W2 gravity. So after the 48 weeks of the initiation of the ART, so this has been added in our first line regimen. Another alternative regimen has been also given. So suppose this any patient develop any side effect of drug or any drug interaction, we can go for the alternative regimen. For example, the above can be there, lanibody can be there, can be there. These are all the alternative regimens for the case of adult. Now this is our second line regimen. If we are getting the end user in the evidence of any treatment failure, we should have to switch to the second line regimen. So this is the second line regimen given by our national guidelines here. For example, that is the gravity, tenofovir, and then the D.K.D. Similarly, alternative was if the again second line regimen is developing any side effect, we can go for the alternative second line regimen. That is the D.K.D again lanibody and etazanavir. So in this, this is the treatment that we will, or the drug that we will prescribe in the case of the adult. Apart from this ART, some general care as well as preventive interventions should be also provided. For example, if the psychosocial counseling is very much important, also we should do the TB screening as preventive therapy should be done, and adequate nutritional counseling should be also given to the patient as well as the pharmacological prophylaxis we can also prescribe. So and now let's talk about how the treatment of the HIV infection in the case of the children. Right? So for the children, again, before starting the ART, we should have to prepare the children for the ART also. So for the preparation, our national guidance has given some points also that we should have to follow. Before starting the ART in the case of children, some baseline investigations taken down here. For example, hemoglobin TLC platelet count ESR should be done, and also for the alanine transferase for the liver function test, volatility and creatinine for the renal function test, and also CD4 percentage count for the chest X-ray, and also random blood score should be done as a baseline investigation in the case of the HIV infection in children. And apart from that, if any children that we enrolled in the care or assess for the ART also is screened for tuberculosis, and also we should provide the all tuberculosis profiling to all the children have HIV infection. And also the psychological counseling, education and support should be given to the guardian of the children that is having infected here about the goal, about explaining the goals of ART, what is the essence of ART to the ART, and also the nutrition counseling should be also given to the guardian also. So after that we can start the resume in the case of children here. This is the first resume that will be given out as the guidelines, that is according to age group. Like for example, information of 1 month of age, then 1 month of 6 years, more than 6 years and 10 years, then after 10 years. So like we can see that in the new list of the 1 month of age, we can use the nebulizer, digobutin and then lamivudin also. Then in the 1 month to 6 years, evacauprid, lamivudin, obigapril. And in the more than 6 years to up to 10 years, one extra that is drug is we can see dolutegravir. We have to notice here that in above dolutegravir has not been added, but after 6 years dolutegravir has been added. There is a significant behind that. We cannot use the dolutegravir as earlier mentioned. It is a very effective drug in our population, so it should be used. But in earlier there is side of the dolutegravir also that earlier age group infant cannot tolerate, or also the dolutegravir comes in the film coated tablet of 50 mg. That is not available. That so the infant cannot take this tablet as a whole. So this is not given in the case of the older age, but it is added after the 6 years because of so dolutegravir can be given for that. The age of the patient should be more than 6 years and weight should be more than 20 kg. So this is the after 10 years another 10 and dolutegravir has also given here. So now here after giving the different drug to the adult and the also children here, people is not completed here. We have to also monitor the patient of the ART because there can be their body monitoring can be the drug that helps detect the drug toxicity or the drug resistance or any treatment failure. So that RDA still can be taken and we can switch to the second arrangement earlier. So for the monitoring we do the many clinical monitoring, industrial monitoring and the high-dose monitoring here. So for the clinical monitoring, the monthly clinical monitoring should be done. That mainly include the weight of the patient, overall well-being of the patient, and then symptom of tuberculosis or not, or any side effect that is developing in or also drug interaction also. So because while starting the ART, this always or any side effect will come in the first 3 months of the ART mostly. So we have to monitor the patient on a monthly basis. Another one monitoring the our emotional monitoring. For the emotional monitoring, we do the CD4 cell count or the percentage. So it is mainly done on a 6 monthly basis here because while using the ART, the CD4 cell count start rising in the first years of life, it becomes a plateau and again it will start to on the second year of the treatment. So this CD4 cell count should be monitored every 6 months. And another is the virological monitoring. The virological monitoring we indicate the viral load is here. So first it will be assessed as a 6 months of the treatment, then as a 12 months of the treatment here, and then after it will monitor every 12 months, it is every 1 year. But if the patient is stable, we can do the less than 50 copies per ml, we can assess the viral monitoring every 12 months. This is also some after monitoring this 3 points. We should also monitor for the any drug specific laboratory parameter also because there can be developmental side effect also. So according to drug, this levels I explained like 10 or 14 I explained the radar toxicity here. So we should monitor this drug in the activity at 3 months first and then at 6 months every 6 months. Similarly, the digobutin has side effect anemia, neutropenia, and then also more max suppression here. So we have to decrease the hemoglobin and then have complete turnover also. And dolutegravir we have to assess for the alanine aminotransferase for the liver toxicity. After that, monitoring will point at the treatment failure can be there. After starting the ART, there is also chance of treatment failure. So treatment failure means in simple language, if any individual is taking the ART here, that ART is completely failing, is not working on the patient. So WHO has given that is a proper definition is there. That is a persistent detectable viral load that is more than 1,000 copies per ml on the 2.62 measurements within the 3-month period, but with as support to the ART should be there between the measurement after the 6 months of the initiation of the ART. If this definition fulfilled, then we can call the case as a treatment failure. So this treatment failure can be also 3 types according to that is the physical failure can be there, industrial failure also and the virological failure. for the clinical failure, it is defined as a new or recurrent clinical event and indicating that advanced liver disease. For example, documented in the progression who is in 3 or 4 after the 6 months of the ART, then what is a clinical failure? There can be also immunological failure for the immunological failure again criteria is given for the separately for the adult and children also. For the adult, if the CD4 cell count is below the 150 cells per million following the clinical failure, or if the persistent CD4 cell count is less than 100 cells per million, then we call the case as a clinical failure in the case of the adult. But in the case of the children, it is given according to age group also, that is if the younger than is 5 years, the CD4 count is less than 200, and if the more than 5 years, the CD4 cell count is less than 100 cells per million, then we label the case as a immunological failure in the case of children. For the hierarchical failure, it is same as the earlier definition. I have explained that hierarchy should be more than 1,000 copies per ml or 2 consecutive measurement after 6 months of treatment within the 3-month period. So this is the treatment failure. Now this is the monitoring algorithm for the treatment failure. Suppose we are doing the routine viral load monitoring, right? And we get the different viral load can be detected. Like for example, first we are detecting the less than 50 copies per ml. Then it shows that the ART is working here, right? So we have to maintain that indicator will drop in the main, and again after 3 months, every 3 months we can have to monitor the patient. And what if the viral load is coming above the 50 cells per ml but below the 1,000 copies per ml? What if the viral load is more than 1,000 copies per ml? Then we have to provide the enhanced air response to both the patient here, and then we have to repeat the viral load every 3 months. And if after 3 months if we repeat it and again, then for example, and less than 1,000 copies per ml in the first case, we have to maintain the indicator drop element, and again counseling the errors to be continued. But if on 3 months period, the viral load is more than 1,000 copies per ml, we have to switch the drop element to the appropriate regimen, that is another secondary regimen. So in this way, we can monitor the patient or treatment failure also. In the case of the DF prophylaxis, DF prophylaxis will be given to the individual who is the HIV not infected, right? So there is also some indication and contraindication for the DF prophylaxis here. So if the individual is HIV negative but his sexual partner is HIV positive, then we have to provide the DF prophylaxis. Similarly, if the individual is having this end of sexual intercourse with a sexual partner without any contact, then we have to also provide the DF prophylaxis. There is also contraindication for the DF prophylaxis. If the HIV is already diagnosed in the case of the HIV positive here, we do not give the DF prophylaxis to the patient. Also, if also estimated creatinine clearance is less than 60 ml per minute, also we should not give the DF prophylaxis. This is a regimen that has been given here. This is the first regimen is the tenofovir, and or emtricitabine can be given if any side effect has been mentioned or there is evidence found here. We go for the alternative regimen, that is the laboratory with the tenofovir. And then after this is the post-exposure prophylaxis also here. It has indication has been also given here for that exposed person is HIV negative, but exposed person is HIV positive. And it is very much important in the case of the sexual assault patient also, because we have to provide the post-exposure prophylaxis. And then another point is that this post-exposure prophylaxis should be as soon as it should be provided to the patient, or more preferably within 2 hours, or maximum is 72 hours of the treatment here. But before providing the post-exposure prophylaxis here, proper counseling should be also provided and the consent should be also taken. This is the drug regimen that is given in the post-exposure prophylaxis to the patient here. So this is